Okay, well, good. As I say, good afternoon, everyone, and welcome to today's paediatric teaching. This is a continuation of the previous two sessions that we had on physiology and basic sciences behind child health and paediatric illness. And previously, we've covered respiratory and cardiovascular, and today we'll try to cover neurology, haematology, endocrine, and renal. It's a lot to get through, but this is the last lecture before the before revision week next week, and the exams the following week, and before the part 1 exams next week. So I just wanted to try to cover all of these areas in the hope that this is somewhat revisionary for you. So again, the way I've structured this talk is to pose a question, a clinical problem, and to try to explain the basic science behind it. And that basic science could be physiology, anatomy, pathology, pathophysiology, immunology, etc., etc. Just the basic sciences behind the clinical phenomena, because that's really the way the often exams are structured and questions are structured, but it also relates to the clinical things we see every day. So the first sort of issue is explain the neuropathology seen in central nervous system tuberculosis. Obviously, we see a lot of central nervous system tuberculosis. It could be TB, meningitis, or tuberculoma, or other forms of central nervous system TB. And it's important to us to understand the neuropathology behind it. And firstly, to understand where central nervous system TB comes from, well, it's a progressive primary infection, usually that occurs in infants and young children. And it usually occurs either because of a progressive primary infection or because of a reinfection of TB. And it's just like where there's a focal source of sepsis followed by a bacteremia that leads to systemic illness. In TB with primary infection or reactivation TB, there's a basilemia. It is a bacteremia because Mycobacterium tuberculosis is a bacteria, but it's often called a basilemia, which just means the bacteria are circulating in the blood. And that can follow or accompany the primary infection when there's before it's more walled off within the lung, or it can occur in reactivation TB. And there's then scattered tuberculous foci throughout the brain. And what happens after the bacilli lodge in certain areas in the brain is there's lymphocytic infiltration, inflammation, and that leads to granuloma formation, which is just small multiple lymphocytes and inflammatory cells all merging in an area of tissue, or even in tubercules, which are really conglomerates of granuloma that then break down and liquefy and caseate within the brain or the meninges or the adjacent bone. Obviously, with Pott's disease, that's what happens. Typically, if there's subependymal tubercle, that means the subependymal layer is just below the ependyma in the lateral ventricles of the brain. Then there can be progression and rupture of these subependymal granulomas into the ventricles, and that's typically what leads to tuberculous meningitis. So there can be the inflammatory change that leads to granuloma formation or tuberculoma formation, or it can rupture into the subarachnoid space, into the into the cerebrospinal fluid, leading to TB meningitis and setting up the same level of inflammation within the spinal fluid. So sometimes there's just meningeal inflammation if there's just an erosion into the ventricles, and then infection in the meninges. And sometimes it can be a tuberculoma where caseating granulomatous inflammatory cells within the brain tissue grow and grow, and then they form a tuberculoma. Sometimes there can be spinal TB, that's not central nervous system TB, but peripheral nervous system TB, spinal tuberculous arachnoiditis, which is just the same thing happening in the arachnoid villi of the spinal canal, and then sometimes that can rupture into the adjacent bone, leading to Pott's disease, a breakdown of bone, and obviously compression fractures of the bone, and leading to spinal cord compression. Sometimes when the inflammation is the granulomas are large enough and they form tuberculomas, or if there's a inflammation of the vessels within the brain leading to cerebritis, that can lead to stroke. So what we see in a child who's got very severe central nervous system TB is a combination of granuloma formation, tuberculomas sometimes, that rupture into the CSF space, leading to meningitis, and sometimes strokes, either from cerebritis, which is an inflammation of the vessels of the brain, or a stroke from a space-occupying lesion like a tuberculoma. And then sometimes, because there's inflammation of especially around the ventricles and in the subarachnoid space, especially at the base of the brain, especially the inflammatory inflammation at the base of the brain, leading to lymphocytic infiltration and granuloma formation, that can block up the arachnoid granulations, which are just little outpouchings of the arachnoid villi that outpouch into the venous sinuses. And so from that allows cerebrospinal fluid to be absorbed, and then to be absorbed within the venous system, and then return to that's how we're producing about 20 mils of cerebrospinal fluid an hour, and all of that's absorbed. But when there's an inflammation of these arachnoid granulations, which are really just these little outpouchings into the venous sinus system, then there's not the same absorptive capacity of that CSF circulation system, and that can lead to communicating hydrocephalus. And then sometimes, of course, with TB, you can have non-communicating hydrocephalus that occurs because of a tuberculoma or inflammation obstructing the ventricular system, if the tuberculoma is large enough. And sometimes when there's, in terms of other pathology, sometimes because of inflammation and stroke or cerebral tissue atrophy, there's the appearance of hydrocephalus where there's large ventricles, and often the sulci and villus, the sulcal pattern of the brain is more capacious. There's more space around the brain in general with large ventricles, and there seems to be less cerebral substance. That can give the appearance of hydrocephalus, but actually it's just what is sometimes called hydrocephalus ex vacuo, which just means there's diffuse cerebral atrophy leading to the appearance of hydrocephalus. So sometimes there can be true hydrocephalus under pressure because of increased or reduced absorption of the cerebrospinal fluid. Sometimes it can be non-communicating because of a tuberculoma of the CSF, and sometimes there can just be widespread cerebral atrophy leading to the appearance of hydrocephalus. The last sort of neuropathology of CNS TB is cerebral wasting, and many children that have CNS TB have hyponatremia, and sometimes that's because of increased antidiuretic hormone levels, but sometimes it's a direct effect of salt wasting by the kidneys. TB can lead to a natriuresis, wasting of sodium by the kidneys. That can lead to hyponatremia. So all of those things can be part of the neuropathology of central nervous system TB, and it's an explanation as to why we see the clinical features that we do in children who've got especially advanced TB. Now, not all children have all of these features. Some will just have meningeal inflammation without granulomatous formation in the brain or without hydrocephalus, but many of the most unwell children who have the poorest conscious levels or have complicated CNS TB, they'll have many of these features. Okay. Now, the second question I wanted to address was explain the neuropathology of the neuropathological basis of 3 different causes of acute flaccid paralysis. You could get asked this question, and of course, when we think of acute flaccid paralysis, we always think of polio, but there's other causes of acute flaccid paralysis, and they have different neuropathology. And so it is important to try to understand the differences between the two. So I've just listed here a number of conditions that lead to acute flaccid paralysis, and what part of the nervous system they affect. So polio is an enterovirus. As you know, it's an enteroviral infection that leads to essentially an aseptic meningitis. Aseptic means there's no bacteria isolated. An aseptic meningitis with a lymphocyte predominance, which suggests it's viral in nature. Of course, it's enterovirus. And it infects particularly the anterior horn cells, but you get some CSF inflammation, usually a moderately high lymphocyte count and not a very high protein level. So the anterior horn cells are the motor cells of the cell bodies of the motor nerves of the peripheral nervous system, and so it's infecting the spine and the anterior horn cells. Guillain-Barré syndrome is a different sort of acute flaccid paralysis. It doesn't affect the anterior horn cells. It actually affects the myelin sheath of the peripheral nerves. It's a immune-mediated polyneuropathy, so not a direct inflammation from a virus, but usually an immune response to a previous or recent infection directed towards the myelin or the axon of the peripheral nerve. So there can be axonal degeneration, but in most cases of Guillain-Barré syndrome, that it's the myelin sheath that's mostly affected. And the myelin, as you know, is a layer of fat that goes around the peripheral nerve, and that gets invaded by inflammatory cells in response. Usually as a sort of autoimmune disorder where there's activated T cells and then macrophages leading to demyelination or loss of myelin and an immune inflammatory response to destroy the myelin. And if nerves, the reason why we have myelin, this fat covering the nerves, is because it improves the rate of conduction of electrical activity along the nerve. And so babies, when they're first born, don't have that much myelin, and you get myelination in the first few years of life. And that's why babies can develop from not being able to do very much to being able to do more complex things and have better eye-hand coordination, etc. That's because of the progression of the growth of the nervous system and especially the myelination of peripheral nerves. And usually Guillain-Barré syndrome follows some sort of infection, and there are certain infections that are a bit more commonly associated with Guillain-Barré syndrome. So Campylobacter is the main one. It occurs in around about 35%, 30% of all cases of Guillain-Barré syndrome. But there are other infections that can also lead to a post-infectious Guillain-Barré syndrome. So certainly it's relatively commonly seen with influenza, sometimes with Epstein-Barr virus. I've seen it with that. Also reported with cytomegalovirus and Zika virus. Certainly in the Zika virus outbreak, there were some cases of Guillain-Barré-like syndrome. COVID as well has been increased numbers of cases of Guillain-Barré syndrome with SARS-CoV-2 and also with HIV. There is a syndrome, Guillain-Barré syndrome, that can be associated with HIV. So the main thing to remember, it's the anterior horn cells that are most affected with polio, and it's an enterovirus infection. In Guillain-Barré syndrome, it's a immune-mediated polyneuropathy affecting the myelin sheath of the peripheral nerves. Now, botulism is another form of acute flaccid paralysis, And botulism is obviously due to Clostridium botulinum, and the botulinum toxin binds to presynaptic receptors, and they block cholinergic neuromuscular innervation. That is, they block the release of acetylcholine from the presynaptic neuromuscular receptor. And so a child who has botulism will, it's like it's the opposite of tetanus, but the same pathological principle, as in the toxin blocks a receptor, and with tetanus there's unopposed activity of acetylcholine, and with botulism there's a block in the secretion, secretion into the neuromuscular junction of acetylcholine, and that also produces acute flaccid paralysis. Botulism, importantly, I suppose, the clinical features, how to recognize botulism. Virtually all children have widely dilated pupils and also constipation. So they're the two features that set it apart in a way from Guillain-Barré syndrome, which is often preceded by a diarrheal illness, and polio, which is an enterovirus. Botulism children, babies, they're usually babies in the first in the first year, but often in the first months of life, and they typically have acute flaccid paralysis with pupillary dilatation and a preceding history of constipation. The last form of acute flaccid paralysis I wanted to just mention in terms of the neuropathology. So if you're asked to explain the neuropathological differences between these different sorts of AFP, then you'd have another one to suggest. And the last one is spinal muscular atrophy, and that is an inherited condition, and it's a deficiency of survivor motor neuron protein, SMN protein, and that leads to degeneration of the anterior horn cells. So it can look a bit like polio, except that it's not focal, whereas polio is focal. It focally affects anterior horn cells, and then you get a focal flaccidity, focal flaccid paralysis. It's not focal, and it typically comes on in the first few months of life, and then certainly evident by 4 to 6 months of life. These babies are more floppy than normal, and by 12 months, usually the respiratory system is affected. These days, there can be there's some certain enzyme replacement therapies for this survivor motor neuron protein, and that's a new way of treating spinal muscular atrophy. But I think just remember, it's an inherited condition that leads to degeneration of the anterior horn cells, but not focally like with polio. It's a widespread condition involving all the nerves. There are some other forms of acute flaccid paralysis that you could use as examples also, such as transverse myelitis, which is usually a post-infectious inflammatory condition that just leads to a spinal, essentially a spinal block, inflammation at a certain spinal level. And those children look like they've got maybe Pott's disease or maybe a spinal cord injury of some sort. And then lastly, hypokalemic periodic paralysis, which we see quite a lot in children who've got either renal tubular acidosis or severe hypokalemia related to diarrheal disease, and they can look very floppy too. So you could describe the neuropathology for different sorts of acute flaccid paralysis if you were asked that question. Right. Next, I want to try to explain the effects of a stroke involving the middle cerebral artery. This again would be a question not uncommonly asked in some examinations, especially the adult Part 1 exam. And so in the Common Core, you could get asked about a middle cerebral artery stroke. And I think it's useful to just have understand the effects of a stroke, the clinical effects of a stroke, and the neuropathology. Well, firstly, remember, because the nerve fibers cross over, there's contralateral, whichever side the stroke is on, it predominantly affects the contralateral side. So there's contralateral gaze palsy. That is, the person affected by the stroke will be gazing to the opposite side. They'll have a hemiplegia, again contralateral, hemisensory loss, and they may have spatial neglect and aphasia if it's on the left side. That's where the uh, expressive and receptive aphasia, that's mediated usually by the left side of the brain. So they're the main things, the gross things that typically people see, but there are also some subtleties of motor dysfunction. Firstly, apraxis, that is difficulty with motor planning. Sometimes there's, there was a syndrome described some time ago, even in patients who don't have severe hemiplegia, they may have what's called Gerstmann syndrome, which is their complex motor tasks they can't do, such as acalculia. They can't calculate numbers, agraphia, inability to write, finger agnosia, not being able to do the finger nose test, and right left disorientation. That would be a common feature of someone who's had a minor stroke or recovering their motor function from a major stroke. And sometimes, of course, the neuropathology includes cerebral edema, and usually that's focal. If you've got a middle cerebral artery stroke, then you get cerebral edema around that area where the brain is injured. Again, a relatively common question that would come up in the Common Core examination for part 1. Okay, I'm going to now switch to haematology and immunology just to gain some relatively common things that we see. Firstly, explain the elements of the full blood count, or the FBC or FBE, and the blood film, which might indicate infection. And I think this is an important thing for us to be able to do clinically. Usually we think about, well, when the white cell count's high, that suggests an infection, but there's a lot more to the full blood count than that. And this would be a good question to ask, both in many different ways within the examination. And I've listed here a variety of different features that tell us some different things about the likelihood of infection. The first one is an elevated white cell count. Of course, we know that it suggests infection, but it's very non-specific. It doesn't tell you whether it's viral or bacterial. The second one is an elevated neutrophil count. Now, again, that's more likely to be bacterial, but it's still non-specific. It's not conclusive. Sometimes we see what's called a leukemoid reaction, which is a white cell count usually that's extremely high, like more than 40,000, and the blood film looks like a bit like leukemia in that there's immature forms. So there's often myelocytes or metamyelocytes or lots of band forms, not so much myeloblasts or very leukemic looking cells, but there's a leukemoid reaction with a lot of immature forms. That's almost certainly, you see that in severe bacterial sepsis, and if you do see that, then you have to take very careful notice of it, because it suggests the child's got a very severe, often they've got a form of bacterial sepsis where there's not adequate source control at this time, and then you have to go and find where the source of the infection is and deal with that, whether it's draining pus or whatever. But typically, I mean, that's relatively rare to see a leukemoid reaction, but if you do, just be really alert for it. But more typically, you see a left shift of the granulocytes. Now, remember, the granulocytes are neutrophils, eosinophils, basophils, but mostly neutrophils. And there's often a left shift, which means there's more immature forms, so myelocytes and metamyelocytes. And there's what sometimes referred to as a high immature to total granulocyte ratio. If you look at all the granulocytes, a higher proportion of them are immature than what you'd normally see in the peripheral blood. And that's quite specific for bacterial infection. If you see that high immature to total granulocyte ratio with lots of myelocytes and metamyelocytes, sometimes some laboratories call it a toxic left shift. It means the same thing. Sometimes with severe bacterial infection, you'll see not a high white cell count, but a low white cell count. There'll be neutropenia. And that too is highly suggestive of a severe bacterial sepsis. Sometimes there'll be a lymphocytosis, a very high lymphocyte count. And again, that's very common in viral infections. If it's very high, though, think of pertussis. In pertussis, Bordetella pertussis, in whooping cough, it's the one viral infection where you get a very high lymphocyte count. Well, it's a bacterial infection, I should say. The one bacterial infection where you get a very high lymphocyte count, and sometimes even up to 30 or 40,000 lymphocytes in the peripheral blood in an infant who's got whooping cough or pertussis. Often in children who've got infections, you'll see lymphocytopenia, that is low lymphocytes, like you'll see neutropenia. And that's very common in acute viral infections, even children who are not very sick. So if a child gets RSV, respiratory syncytial virus, or they get parainfluenza, then they'll typically get lymphocytopenia or lymphopenia, and that will last for a few days, and then it usually recovers. Beyond the white cells, you can also look at other features of the full blood count, and certainly thrombocytosis. If you see a platelet count that's above 700,000, then that's a very high risk of bacterial sepsis. The higher the platelet count, the more likely it is that the underlying cause is bacterial sepsis. Again, a bit like a leukemoid reaction, you need to treat it very seriously. A child who's got a thrombocytosis with a platelet count of 800 or 900 or 1 million even. Sometimes obviously with viral infections, you can get thrombocytopenia, and that's also seen in dengue. So it's another feature of infection, non-specific, but sometimes associated with viral infection, sometimes associated with dengue, for example. Anemia is very common in the full blood count in children who've got in children who've got infections, but it is non-specific, and sometimes with anemia you get red cell fragmentation, suggesting hemolysis, and that can be due to severe sepsis if the child's got severe sepsis, or with a sepsis-like syndrome called hemolytic uremic syndrome, where there's hemolysis. So it's non-specific, but very common in children with infections. And sometimes, of course, in the blood film, you can see malaria parasites or even bacteria. Sometimes will be seen on the blood film if there's a severe bacteremia, or obviously malaria parasites in a blood film. And then sometimes there will be the sign of infection that suggests some sort of parasitic infection, like a helminths or toxicara or trichinosis or protozoal infection. Any other parasites will give you an eosinophilia, of course, seen in allergy and parasitic infections. So you can look in detail at the full blood count and really try to understand what the different signs that tell you that there might be infection there. Okay. All right. This question is about a haematology question about the pathophysiology and genetics of bleeding disorders. And if you were to get this question, I mean, it might come up in a variety of different ways. You'd really just need to understand the difference between hemophilia, von Willebrand's disease, and other bleeding disorders such as ITP, immune thrombocytopenia purpura. And the most common bleeding disorder in children is not hemophilia or von Willebrand's disease, it is ITP. And in ITP, it can follow viral infections. It's usually acquired. Sometimes it can be congenital because of antibodies from the mother can attack. That's called alloimmune neonatal thrombocytopenia. But usually it's acquired and it follows a viral infection. It can coexist with a viral infection. And what it means is that there's reduced platelet lifespan. So instead of the platelets lasting their usual lifespan there, it's reduced because there's antibodies to the virus that cross-react with the platelets that then get taken up by the spleen and sequestered within the spleen. And we learned earlier on in the year what the splenic function is, and that is to remove aging or dysfunctional or red cells and platelets particularly. And so you get immune-mediated splenic sequestration. It means they're sucked up into the spleen and then removed from the circulation. As I say, it's usually acquired ITP, so rarely has a genetic background to it. The genetic conditions are obviously hemophilia and von Willebrand's disease. And haemophilia, remember, is factor 8 and factor 9 deficiency. Haemophilia A is factor 8 and haemophilia B is factor 9. And they're X-linked conditions. And just to understand a bit of the genetics of it, a third of them are new mutations, so there won't be a family history, but most are X-linked conditions that lead to haemophilia A, an X-linked condition that leads mostly to bleeding in boys, male babies and male children. And as you know, we've talked about haemophilia before, but it leads to haemarthrosis. That's the typical bleeding problem of children with haemophilia. Depending on how low the factor 8 or factor 9 levels are, there can be other intra-organic organ bleeding, bleeding from the gastrointestinal tract, bleeding from the urine, bleeding from the umbilical cord, bleeding into the lungs, the brain, bleeding on minor trauma, etc., and spontaneous bleeding if it's very low. If it's less than 1% factor 8 or factor 9, then there'll be bleeding, spontaneous bleeding into joints, especially. The von Willebrand's disease is different. It's an autosomal dominant condition, and it's related to a deficiency of von Willebrand's factor, which when we are forming little breaches in our endothelium all the time, and there's when you get a breach in the endothelium, you then get a platelet plug, and the platelet plug combines with the coagulation cascade and then forms a clot, and it adheres to the damaged endothelium using von Willebrand's factor, which is a form of factor 8, and it's produced by endothelial cells and megakaryocytes. So megakaryocytes being the precursors of platelets. And they're large molecules that just know that they're responsible for the adhesive bridge between a platelet plug and a damaged endothelium. And if you don't have that, then you have a prolonged bleeding time. It's different in its hematological manifestations, clinical manifestations, and its genetics from haemophilia. You can still get nosebleeds and mucosal bleeds. They're more common than haemarthrosis in von Willebrand's disease. Okay. The next question is to explain the pathophysiological effects and compensatory mechanisms of anemia on oxygen delivery. And this is an important question because we see a lot of children who have hypoxemia or anemia, and it's important to know just how that affects their body, how it affects the organ function, how it affects normal metabolism. And what you need to know is the oxygen delivery equation. And that's the cardiac output times the hemoglobin times the oxygen saturation times a factor of 1.31, which is the amount of hemoglobin that's contained in a gram of the amount of oxygen can be carried by a gram of hemoglobin. So the cardiac output, which is the heart rate times the stroke volume times the hemoglobin times the oxygen saturation times this constant factor, that tells you the oxygen delivery to tissues, the amount of oxygen that can be delivered to tissues. So if your hemoglobin is low, then your oxygen, your DO2, your oxygen level, your oxygen delivery to tissues will be reduced. Similarly, if your oxygen saturation is low, then your oxygen delivery to tissue will be reduced. But there are compensatory mechanisms that can compensate for a low amount of any of those. So if a child's got severe hypoxemia, then often their cardiac output will be increased, or over time, over a long time, their hemoglobin will increase. If you're living at altitude where your saturation is typically low, then your kidneys will produce more erythropoietin and you'll make more hemoglobin. Your bone marrow will make more hemoglobin. And similarly, there are compensatory mechanisms for a low hemoglobin that will compensate for the loss of oxygen delivery, and they are to increase the cardiac output. So if you have anemia, then the body responds by increasing cardiac output, increasing tachycardia, increasing stroke volume. Together, the stroke volume times the heart rate equals the cardiac output in the liters per minute per meter squared, etc. So anytime the hemoglobin drops, then you'll have an increased cardiac output. And that's why you see children that have one of the cardinal features of anemia is tachycardia, hyperdynamic circulation. There's also a response by the body to retain more water, to maintain the intravascular volume, and therefore be able to maintain that hyperdynamic circulation. And so a child who's got a chronic form of anemia will often have, that's not due to hemorrhage, will often have an increased circulating blood volume, except their blood count will be low. They'll have an increased circulating intravascular volume, but their blood count will be very low. And children with anemia get tachypnea, usually to optimize their oxygenation. So you can compensate for the low hemoglobin by increasing tachypnea and optimizing your oxygen saturation. Not much. You can't do it too much, but you can do it. The tachypnea is also because of an increased circulating blood volume and the stress that it puts on the heart and the lungs, of more blood going through the lungs. There is also a compensatory mechanism not by the oxygen delivery equation, but by an increased oxygen extraction by tissues. So therefore, if your hemoglobin is low, then you'll extract more oxygen from the blood into the tissues, and therefore the amount of oxygen that's in your venous circulation will be lower. You can measure that. You can measure the venous oxygen saturation, and that'll often be quite low. The normal venous oxygen saturation is about 70 or 75, but sometimes with severe anemia, your venous oxygen saturation might be 40 or 50. That's also seen where you've got a low cardiac output. You increase the extraction of oxygen by tissues as a compensation for the low cardiac output to maintain oxygen delivery to tissues. And then finally, depending on the cause of anemia, the body responds by increasing erythropoietin production or secretion by the kidneys, and that increases hemoglobin production by the bone marrow. So you can understand all of this if you understand the oxygen delivery equation, and I just you can then work out what things change in response to anemia or even hypoxemia. Okay. Now, a common question would be to describe the effect of the HIV virus on cells of the immune system. And I think you'll have studied this. Hopefully you've gone through this, but I just want to give the basics of what actually happens when a person is infected by the HIV virus. We all know about CD4 cells and others that are affected, but just firstly, the HIV virus doesn't target all cells. It targets particularly dendritic cells and macrophages and CD4 positive T cells. That's what you need to know. Both the dendritic cells and the macrophages have a glycoprotein, and they have antigens on them that the glycoprotein GP120, which is on the virus, a glycoprotein on the virus, it binds to the CD4 molecule. It also binds to this CCR5, which is a chemokine receptor on immune cells. The main thing is there are antigen receptors on the immune cells, the CD4 positive T cells and the macrophages and the dendritic cells that can bind the glycoprotein 120 from the HIV virus. The viral RNA then replicates within cells. Remember, all viruses, they can't replicate alone. They only replicate within cells. So it penetrates the cells and replicates within those CD4 positive cells, and it destroys the T cells. And you then, when the virus replicates in massive amounts and leads to an enormous viremia, and then that's combated somewhat by CD8 cytotoxic lymphocytes. The CD4 cells is where the virus replicates, and CD8 cells try to combat that. And usually there's a wave of viremia to begin with, and then plasma load falls substantially. Okay, so we've talked about neurology, and we talked about haematology and immunology. I just want to cover a little bit about endocrine and renal aspects in the last 20 minutes or so. So explain the pathogenesis of insulin-dependent diabetes mellitus. And I think this is important to know. Diabetes is becoming a bit more common. WHO are just producing guidelines on the management of diabetes. So we should know about this. This is not to start with, not the pathogenesis of DKA. It's the pathogenesis of type 1 diabetes. And it's a little bit like Guillain-Barré syndrome. It's an autoimmune disorder where there's autoimmune destruction of insulin-producing beta cells in the islets of Langerhans within the pancreas. There is both a genetic susceptibility to type 1 diabetes, but it's also triggered by many different environmental agents. We know there's genetic markers, multiple genetic loci that predispose to type 1 diabetes. But there's also, and we know that many children that get diabetes, when in the first few months, even months beforehand, often if you could predict which children would get diabetes by measuring their islet cell autoantibodies, you'd find them for several weeks or months beforehand. And now in some countries, they're starting to measure these islet cell autoantibodies, and that's a state called pre-diabetes, and it can lead to treatments that can actually prevent diabetes. Very difficult to predict which children are going to get diabetes, but what we know is that most diabetes follows some sort of viral infection. Certainly, Coxsackie B virus is found in close to 40% of all children who have newly diagnosed diabetes mellitus and type 1 diabetes and or enterovirus. So those two viruses, Coxsackie B virus and enterovirus, are found very commonly, and it probably leads to an autoimmune reaction that leads to islet cell autoantibodies, some sort of autoimmune reaction that is against the insulin-producing beta cells in the islets of Langerhans, which are within the pancreas. And usually over weeks or months, there's a inflammation of the pancreas, a form of, but it's very focal inflammation that only affects the islets of Langerhans, not the other pancreatic function, and leads to obviously a loss of the islet cells and reduced insulin secretion. And it's thought that if you can get to the autoimmune dysfunction early enough, before a child has very established diabetes, it might be possible to preserve some of the islets of Langerhans, and the child won't have complete destruction, which is what happens in complete destruction of all insulin-producing cells, which is what happens in established type 1 diabetes, where there's no insulin being produced by the pancreas. Okay. Explain the pathophysiology of diabetic ketoacidosis. So I've talked about the pathophysiology of type 1 diabetes, but the pathophysiology of diabetic ketoacidosis it follows from that. And this would be, again, a question that's fair to ask. Well, the main things to know are, first of all, obviously, insulin deficiency leads to hyperglycemia. Insulin is responsible for the movement of glucose into cells, and if you don't have insulin, then all the glucose in the body is outside cells. It leads to marked hyperglycemia over usually, again, weeks and months. And the hyperglycemia leads to an osmotic diuresis, and the features are polyuria, polydipsia, etc. Because there's hyperglycemia and the glucose can't get within cells, then the glucose can't be used for energy. And so the body has to find an alternative source of energy, and that's usually through ketone bodies. And that occurs because of fat and protein catabolism. So it's a catabolic state. That's why children with diabetes have weight loss, they have hyperglycemia, and they have ketonemia. So when it's a catabolic state where the protein and the muscle are breaking down to make energy, ketone bodies that can be used instead of the glucose. Even though there's lots of glucose in the bloodstream, there's not glucose getting into the cells, so it can't be used for metabolism. This is especially important for the brain, which relies very much on glucose metabolism. It can, however, the brain can, however, use ketone bodies for energy, and that enables the brain to continue functioning even when there's marked hyperglycemia, and there's no insulin, leading to a lack of glucose within the brain. But ketone bodies can be used for energy. But of course, buildup of ketone bodies in the blood, even though it's useful for energy, leads to acidosis, ketoacidosis. It's an acid, and the dehydration you see in diabetes, in DKA, is multifactorial. Firstly, if you get a severe ketosis, then usually you have vomiting. So that's common in children with DKAs, vomiting. Also, when you get dehydration, you get a contraction of the circulation going to the splanchnic circulation, and therefore there's more vomiting because of that. But the main reason for dehydration is an osmotic diuresis, because if there's, with lots of glucose and ketones in the blood, then that glucose is spilling out into the urine, and that obviously takes a lot of water and potassium and other salts with it. And the osmotic diuresis from hyperglycemia and the dehydration that occurs from vomiting and reduced intake, because there's often a period of anorexia that occurs with DKA as it's progressing. Then children present with severe dehydration, hyperglycemia, ketonemia, and severe acidosis. The acidosis is because of those things. The ketosis, because they're ketone bodies that are acid. The dehydration leads to acidosis as well. Hypovolemia from the osmotic diuresis and lack of, inability to keep up with the amount of urine that's being passed. You know that the glucose threshold for the kidneys is around about 12. So if the blood sugar, 11 or 12, if the blood sugar is higher than 11, then usually there'll be some glycosuria. And when there's glycosuria, there's also always an osmotic diuresis, which means because there's osmotic particles, glucose being excreted, then that has to be accompanied by some water, and that's why there's polyuria. There's potassium also lost in the diuresis. Anytime you get a diuresis from furosemide or from an osmotic diuresis, like with hyperglycemia, you lose potassium, and that's occurring at a time when there's no insulin, which is also required to drive potassium into cells. So these patients get profound hypokalemia. They have a total body potassium deficit because they've lost so much in diuresis. But when you start treating with insulin, then that drives potassium into cells, and they'll get hypokalemic. That is, they'll have low potassium in the blood. So all children with diabetes need replacement of potassium as well, as long as they're making urine. Sometimes if they've got such severe dehydration, they've got acute renal failure, then you don't start the potassium straight away. But usually these children come in with polyuria, and they need to be on potassium replacement when you're starting the insulin. We talked about the clinical management of diabetes in a previous lecture. Okay. So this is another question. We have time. A 10-year-old boy presents with weight loss, dehydration, a 10-day-old boy. This is a small baby, a neonate, presents with weight loss, dehydration, hyponatremia, and hyperkalemia, and increased skin pigmentation. And the question would be, explain the pathophysiology of the likely condition. And if you are alert to this, then you'd recognize that hyponatremia and hyperkalemia is typical of adrenal failure. That's the clue to this question, is to recognize the pattern of adrenal failure. And hyponatremia, remember, adrenal failure is where you haven't got aldosterone. Aldosterone retains sodium and excretes potassium. And so when you've got no aldosterone, then you get the opposite of that, hyponatremia and hyperkalemia. And these patients, if they've got Addison's disease early, they have an often increased skin pigmentation. So they've got an Addisonian-like syndrome. And the typical cause of neonatal Addisonian crisis like this is 21 hydroxylase deficiency or congenital adrenal hyperplasia. And that usually occurs because of an enzyme defect known as 21 hydroxylase deficiency. You don't need to know necessarily what enzyme pathway it blocks, but just to know that it's a genetic mutation. There are actually several types of congenital adrenal hyperplasia, not all due to 21 hydroxylase deficiency. There's now a known genetic defect, the CYP21A2 gene. Again, you don't need to know that, but it is worth knowing the different manifestations of congenital adrenal hyperplasia, and it depends on whether you've got no 21 hydroxylase or a bit, or if there's a complete absence or not, and whether you're male or female. So usually when there's severe 21 hydroxylase deficiency in males, then they'll present just like this, the boy that I mentioned. In females, usually it produces atypical or ambiguous genitalia. That's the manifestation. Some males, like this child, have salt losing, so failure to thrive, dehydration, hyponatremia, hyperkalemia. In the first 7 to 14 days, they will present that way. But then there are other males that have a milder form of 21 hydroxylase deficiency, and they are non-salt losing. So they don't typically lose salt, but they have an increased production of hormones that stimulate the sex hormones that try to stimulate the production of cortisol and aldosterone, and it leads to early virilization. If there's no serum cortisol, then there's an Addisonian crisis, but the response to that in developing children is increased virilization, because the pituitary hormones, the hypothalamic and pituitary hormones, are increased, trying to stimulate the adrenals to produce more cortisol. And it's the lack of cortisol that leads to salt wasting or the other effects. But some males just have non-salt wasting 21 hydroxylase deficiency, and they'll just present with early virilization, precocious puberty, if you like. And if there's not enough, if there's enough 21 hydroxylase enzyme for a child, a boy typically, not to get salt wasting or the other features, they may get precocious puberty, because still the cortisol levels in the blood will be low, and there'll still be stimulation because of the block in cortisol production at 21 hydroxylase, and there will still be production of the hypothalamic and pituitary hormones that will lead to precocious puberty. So to know a bit about 21 hydroxylase deficiency is quite important. Okay. Now, lastly, we might try to explain the pathophysiology of the common form of renal tubular acidosis as a last question, I think. So we've gone through RTA before. It's relatively common in examinations, but just to know, I guess, that the most common type is called distal renal tubular acidosis, and it's an impairment in the chloride bicarbonate exchanger in the distal tubules. And the typical features are you get a very high chloride level and a very low bicarbonate. All right, the distal tubules are unable to reabsorb bicarbonate, and instead they retain chloride. So there's a severe metabolic acidosis with a very high chloride and a low bicarbonate level, typically less than 10. And the consequences of that are all linked to this abnormality of the chloride bicarbonate exchanger. And it leads to wasting of calcium and inability to produce vitamin D, and so therefore leads to rickets and nephrocalcinosis because of calcium being deposited in the kidneys. But the clinical features are severe hypokalemia, severe metabolic acidosis with a bicarbonate level that's very low, a high urinary pH because all the bicarbonate is being wasted in the urine, it's not being reabsorbed, and a high alkaline phosphatase because of reabsorption of calcium from bone to maintain the level of calcium. So distal RTA. This would be the typical blood gas of a child who's got renal tubular acidosis. I just want you to look at this. You might get a blood gas, for example, in the exam. Usually it's a metabolic acidosis with respiratory compensation. These babies are often got tachypnea and their bicarbonate level is very low, the normal being about 18 to 25, but bicarbonate being low. The base excess is very negative. That is, they've got a severe metabolic acidosis. Their potassium is very low and their chloride is very high. And when you calculate the anion gap, it's normal. So instead of they don't have a high anion gap metabolic acidosis like you see with ketoacidosis or like you see with lactic acidosis, they have a low anion gap metabolic acidosis. They will be tachypneic and they'll have intercostal retraction. They'll have severe hypokalemia, hyperchloremia, metabolic acidosis, growth problems, nephrocalcinosis, sometimes eye problems as well. Remember we talked about they may have cataracts because the chloride bicarbonate exchanger is also involved in the production of the aqueous humor within the eye. So they might have cataracts, they'll have rickets, they'll have low levels of vitamin D, and those biochemical features of hypokalemia and hyperchloremia. And when they get an episode of diarrhea from any virus, their potassium will go very low and they'll become floppy and often have this hypokalemic periodic paralysis. All right. So just to explain again, distal RTA, that's the most common form. It's a failure of the distal tubules to normally reabsorb filtered bicarbonate through the chloride bicarbonate exchange pump. And the bicarbonate gets wasted in the urine, the chloride gets retained, and so you have very low bicarbonate, very high chloride. There's another form which is called proximal RTA type 2, where you get wasting of bicarbonate in the proximal tubule, and that leads to secondary potassium wasting and an osmotic diuresis, and the features are a bit the same. So, but the chloride is low, the potassium's low, and sorry, the bicarbonate is low, the potassium's low, and the chloride is very high. And then there's another form which is type 4, which is just aldosterone deficiency. Type 3 is extremely rare and almost never discussed, but type 1, 2, and 4. The most common one, the most important one is distal RTA. That's the one that we see most commonly. And as I said, these are the features. You get signs of rickets on X-ray with the metaphyseal flaring of the X-ray, this abnormally sort of rough metaphysis and cupping and flaring of the metaphysis. And if you do a ultrasound of the kidneys, then there'll be nephrocalcinosis typically. I won't go through the other features again, but low bicarbonate, high chloride, high alkaline phosphatase because there's been reabsorption of calcium from bone, and alkaline urine because all the bicarbonate's being wasted in the urine, and usually a very low potassium level. You get rickets because in renal tubular acidosis is impaired conversion. Remember we talked about the kidneys being involved in the conversion of 25-hydroxyvitamin D to 1,25-hydroxyvitamin D, the active form of vitamin D3 in the kidneys, and so it leads to so-called renal rickets, not because of lack of vitamin D in the diet or lack of sun exposure, but because the kidneys can't produce enough active vitamin D. And without active vitamin D, then the kidneys don't absorb the calcium, and you get calcium and phosphate loss in the renal tubules, and leads to calcium deposition and nephrocalcinosis. And all the calcium is leached from the bones, so you get osteopenia and that metaphyseal flaring and the clinical features of rickets. Okay. Now, lastly, explain the pathophysiology and clinical causes of the syndrome of inappropriate ADH. And I think this is something we see commonly in children who've got bronchiolitis or in pneumonia or meningitis, a syndrome of inappropriate ADH, where the antidiuretic hormone level is high relative to the osmolarity of the blood. And it occurs in many different conditions, in meningitis, encephalitis, bronchiolitis, pneumonia, in sepsis, in coma of any reason, lung cancer in adults, brain surgery, it's quite common. And it leads to a high antidiuretic hormone level, which results in an inability to excrete a free water load. What antidiuretic hormone does, it retains water, only water, not sodium so much. But when you've got retention of water, remember it's an aquaporin activator, antidiuretic hormone. When you've got retention of water, that leads to a dilutional hyponatremia. The sodium level goes low, dilutional hypoosmolarity, and that leads to water moving into cells to maintain the osmolarity difference between the intravascular volume, the interstitial fluid, and intracellular fluid. And because of the retention of water, that leads to an increase in intravascular volume, and that leads to a natriuresis. So typically in syndrome of inappropriate ADH, there's two reasons why you have a low sodium. One is that you've got a dilutional hyponatremia, and the other one is because your kidneys are putting out more sodium in the urine, not because of the ADH, but because of the intravascular volume expansion. And so these children present with hyponatremia and a normal or expanded total body water. They usually don't look dehydrated, and they have a moderate, not extreme natriuresis, unlike with cerebral salt wasting, where there's a large loss of sodium in the urine. This is a moderate loss of sodium in the urine, and it's a secondary effect of the expanded intravascular volume. Okay. I'm going to stop sharing my screen now, and I think that is the end. I hope you could see my slides today, and if you've got any questions, then I'm happy to answer them. That was, I obviously covered too much ground today, but I wanted to cover as much as possible in the last lecture and try to get those who are sitting their part 1 exam next week in as good a shape as possible and cover as many things as we could. So I hope that's been useful. I'm going to stop recording now, and I can answer any questions that you have.